Hi guys, welcome to your YouTube channel. I hope your MRCPCH journey is going well. I have been receiving multiple requests and my colleagues have been asking me that it's very difficult to get through the past test MCQs pool because it's taking a lot of time. So I have cracked it for you. We will be discussing the pearls. After this, you don't need to do the past test MCQ pool. So let's start. Our first chapter, that is the blood, which is hematology and oncology. So we will be quickly discussing the exam points which are targeted in exam. Okay, so these are the key concepts which are being tested in past test questions again and again. So after going through these key points, I believe that you will not need to go through all the past test MCQs, and even if you go through them, you are not gonna make much mistakes. Okay, so without wasting any time, let's get into them. Okay, so first is the blood transfusion. This is very commonly tested in exams. Okay, so the one thing is that in UK the blood is screened for HIV-1, HIV-2, hepatitis B, hepatitis C, treponema pallidum for syphilis, and human T-cell leukemia virus. Okay, so apart from this, in immunocompromised patients and recipients who are at high risk, they're also screened for CMV virus. Okay, so this is a very key concept. You need to remember these, that the blood screening is done for these viruses when they are given transfusion. Okay, so the other thing is that a person can't donate blood if he have traveled to malaria endemic area in the last 6 months. Okay, so if a patient has gone to in malaria endemic area, he will not donate blood for at least 6 months. And similarly, if a person gets body piercing or tattooing, okay, so the blood donation is deferred for 12 months. Okay, he can't donate the blood for 12 months. And if he is tested and his core hepatitis B antibody is negative, then he can donate after 6 months. Okay, so what are the contraindication? The absolute deferral if had organ transplant in UK. Okay, if had an organ transplant, then it is a absolute deferral. And the second is risk of drug abuse and exposure to HIV. If a patient has this risk factor, he is absolute deferral, he can't donate blood. Okay, and a person can't donate blood if he is less than 17 years or his weight is less than 50 kg. Next we move on to hyposplenism. So hyposplenism is found in sickle cell disease, celiac disease. They will ask you specifically, okay, dermatitis herpetiformis and SLE. So what you will find on peripheral blood film is Howell jelly bodies, Heinz bodies, nucleated RBCs, siderocytes and acanthocytes. So you need to keep on in mind the hyposplenism. Okay, then there is a typical question asking for the prognostic marker in acute myeloid leukemia. So the prognostic marker is bone marrow karyotyping. Okay, it is the most important prognostic marker in acute myeloid leukemia. So what does this tell us? This tells us if there is translocation at age 21 or chromosome 11 inversion, there is a low risk of relapse. However, if there is mutation at chromosome 3, 5, 7, then there is high risk of relapse. Okay, so the another key point is to remember is that methotrexate is the only drug which is contraindicated or not administered if the neutrophil counts are depleted. You will not give methotrexate. Okay, so another very key point is that bone pain after alcohol consumption. If a patient is having bone pain increased after alcohol consumption, this is rare but characteristic of Hodgkin disease. Okay, Hodgkin disease, remember this one. And important another point is that there is increased platelet may be seen in malignancy, iron deficiency and myeloproliferative disorders. Okay, so another key very important point is that the children's with acute lymphoid leukemia, they rarely sometimes present with testicular swelling. Okay, and they have a testicular swelling, so you need to check for this is also a presentation for acute lymphoid leukemia. So post treatment male patients, they should always be examined for potential relapse. Testis should always be examined for potential relapse. Okay, so then there is another thing, Burkitt lymphoma. Okay, so Burkitt lymphoma, how does this as present is, first of all, it is associated with Epstein-Barr virus. Okay, and there is a positive antibody to Epstein-Barr virus. And number two is there are large lymphoid cells with foamy cytoplasm containing numerous vacuoles. Okay, and now these are two things. If there is a scenario of abdominal mass, okay, liver mass, and is associated with thrombocytosis, increased platelet, okay, so this is hepatoblastoma. And if it is if there is increased HP, polycythemia, then it is hepatocellular carcinoma. This is an important differential point. Okay, so coming next, there is, you have all heard of anti-Rho and anti-Law antibodies. Okay, so these are present in SLE, congenital SLE, which presents with the heart block, third degree heart block. Okay, so they both are present in SLE associated third degree heart block and Sjogren's syndrome. However, anti-Rho antibody is more specific in SLE, and anti-La antibody is more specific for Sjogren disease. Similarly, anti-Jo antibody is positive in myositis or dermatomyositis. Okay, and anti-smooth muscle antibodies is present in autoimmune hepatitis. So coming up next, okay, there is sickle cell disease. Sickle cell disease often present with dactylitis. So important concept which you need to remember is that there are two variants. The normal is HBSS sickle cell disease, and the other variant is HBSC variant. Okay, so the HBSC variant has a characteristic that there are more severe retinal disease, however has mild course than HBSS, but has more severe retinal disease than HBSS. As we talked previously, if there is sore throat with palatal fatigue and the monospot test is positive, it is Epstein-Barr virus. Okay, similarly, there is an ITP. Okay, ITP, you all know that it presents with after an acute viral illness, or it can present with certain drugs or chemotherapies. Okay, so if there is no mucosal bleeding, this is very commonly tested, no mucosal bleeding, then it is at low risk and no need to treat. So discharge and close follow-up for the patient. However, if there is mucosal bleeding, then active treatment is advised. A syndrome which will be very commonly asked from you in the past test and in the exam as well is TAR syndrome. Okay, so it is a triad of absent radius, okay, absent radius or limb or digit deformities, thrombocytopenia, and there are other variable systemic manifestations. So absent radii, thrombocytopenia, and variable other systemic manifestations, and this is AR stands for autosomal recessive. Okay, and when you will look at the BMA, bone marrow bioaspiration, you will do it, there will be myeloid hyperplasia with absence of megakaryocytes, which are the precursor of platelets. So the platelets are going down, thrombocytopenia. So in bone marrow you will find there are decreased megakaryocytes or absent megakaryocytes. Okay, so patients who survive first year of life, their platelet do stabilize, okay, and their count improves and they have a better prognosis. Then there is a key very commonly asked about TLS, okay, tumor lysis syndrome. So you need to remember in tumor lysis syndrome there is increased potassium, increased uric acid, increased phosphate. However, the only one thing which is decreased is calcium. This will be very commonly tested, so do look for it. Okay, and it can lead to renal failure as well. So coming next to Hodgkin lymphoma. So Hodgkin lymphoma, we all know it presents with painless lymphadenopathy and sometimes mediastinal mass. Especially look for this presentation, mediastinal mass. Okay, the patient will present with superior vena cava obstruction, facial flushing, okay, and maybe increased work of breathing or respiratory distress due to airway obstruction. So especially look for this presentation in an exam, okay? And on X-ray you will find mediastinal widening due to mediastinal lymphadenopathy, okay? And its associations are with Epstein-Barr virus, SLE, rheumatoid arthritis, and ataxia telangiectasia, okay? And it has very good prognosis, like 95 to percent is more than 95%. There is 5-year survival, and the age onset is 20 to 40 years, okay? And we previously talked about it, that with alcohol consumption there can be increased bone pain, and this is although very rare but very characteristic of Hodgkin's lymphoma. And in hereditary spherocytosis there is a typical triad: anemia, jaundice, and splenomegaly, okay? And the commonly tested concept will be pigmented gallstones in 85% by the second decade. Then the next is Glandsman thrombostania, okay? So Glandsman thrombostania, we all know, is an autosomal recessive disease, and the gene involved is, and this is a typical question asking for the gene locus, okay? So it is ITGA2B and ITGA3B. So this is the gene which is involved in platelet function disorder, Glandsman thrombostenia. So the treatment is local antifibrinolytics and platelet transfusion if severe, and bone marrow transplant is the long-term treatment. Another very common and very important topic that will be asked from you is the ABO hemolytic disease, okay? So in this, mother blood group will be O positive while the baby blood group will be AB or AB positive, okay? So look for this thing. And the next is RH hemolytic disease. So in RH hemolytic disease, the mother is negative, the baby is positive, okay? It can also have hemolysis in utero, and it can produce hepatosplenomegaly, ascites, and it can present as a hydrops fetalis, okay? So this is very lethal form if it occurs in utero. So the protocol in UK and in European countries is that the mothers are in the RH negative mothers are screened for at booking at 28 weeks and 34 weeks, okay, for RH antibodies. If anti-D antibodies are detected, then they are followed up closely every 2 weeks to check the titer, and if the titer is high, then amniocentesis to measure the bilirubin level in the amniotic fluid to check for the hemolysis, and maybe in utero exchange transfusion would be required. The use of anti-D passive immunization in mothers within 72 hours has reduced the incidence of this disease, okay? So coming up next is anemia of chronic disease. So this is also very commonly tested. So in anemia of chronic disease there is normocytic normochromic anemia, there is low serum iron, but the thing to remember is that there is either normal or increased ferritin, and increased reticuloendothelial stores of iron. So iron is not deficient, okay? Iron is not deficient. Serum iron is low, but the stores are there, it can't be mobilized, okay? And so the ferritin is also increased, or it's normal. And there will be low iron bonding capacity and transferrin saturation. So summing up, low serum iron, okay, normal or increased ferritin, and low iron bonding capacity and transferrin saturation, okay? So iron supplements are given. This is a MCQ, we will be asked about this. Iron supplements are given if serum ferritin is less than 50 microgram per ml, and may improve anemia if coexistent iron deficiency anemia. Hemoglobin not usually less than 9. So hemoglobin is not very down, okay? So they are given iron supplements if serum ferritin is less than 50 microgram. So this will improve if there is coexistent iron deficiency anemia. Coming up next is DiGeorge syndrome, a congenital syndrome, okay, catch-22, gene located on chromosome 22. This presents with thymic aplasia, hypoplasia, or hypoparathyroid hypocalcemia with seizures, congenital heart diseases which include right-sided aortic arch, AVST, hypoplastic pulmonary artery, low set ears, hypertelorism, anti-mongoloid slants, and lymphocyte may be normal, down, or increased. So thymic hypoplasia, hypocalcemia, congenital heart disease, especially look for right-sided aortic arch, and hypoplastic pulmonary artery. Hypoplastic, these two are very important, okay, because they are different. So coming up next, iron toxicity. So iron is toxic when it is taken at 60 milligram per kg or more. It causes the toxicity. So if you are suspecting iron toxicity, so what investigation will you do? Do free iron level, okay, and number 2 is X-ray abdomen, okay, because the iron is radiopaque and it can be visualized on the X-rays. Next is carbon monoxide poisoning. So carbon monoxide poisoning, there will be reduced oxygen carrying capacity of the blood, okay, so there will be reduced oxygen carrying capacity of the blood, and this will shift the oxygen dissociation curve to left. This is an MCQ. You will be asked that carbon monoxide poisoning shifts the oxygen dissociation curve to left. So what happens is the partial pressure of oxygen is normal, but oxygen content in the blood is low. So if there is 10% carboxyhemoglobin, when the carbon monoxide binds with hemoglobin, it forms carboxyhemoglobin. If it is 10%, there will be no symptom. If it is 10 to 30%, there will be headache and dyspnea, and if it is around 60%, it will cause coma, convulsions, and even death. So as we talked previously, methotrexate is its administration is dependent on neutrophil count, not given in neutropenia. We know this. A very important side effect for vincristine. Look for it. You will definitely find this one in the exam. So a child on chemotherapy comes with limping. So what drug is responsible? It is vincristine. Vincristine causes limping, bone pain, constipation. It causes neurotoxicity. Look for vincristine, neurotoxicity, limping, okay. So look for this one. And we have talked previously about the testicular disease, that testicular swelling. This is a rare presentation in children with leukemia, okay. And we have talked about Burkitt lymphoma, that WBC differentiates normal, present as a mass in the neck, okay, and biopsy shows large lymphoid cells with foamy cytoplasm containing numerous vacuoles. Antibody to Epstein-Barr virus is usually positive. So mass in the neck, antibody positive, WBC differentiation normal, but biopsy shows lymphoid cell with foamy cytoplasm. Remember this. You will definitely get a question on this one: neonatal alloimmune thrombocytopenia and neonatal autoimmune thrombocytopenia. So what are these? And you need to remember the differences between these. So in neonatal alloimmune thrombocytopenia, the alloantibodies are produced by the mother, okay, they are produced by the mother against certain fetal platelet antigen, okay, which the baby inherits from the father, okay. Baby inherits platelet antigen from the mother and from the father, but in this situation what happens is the mother produces antibodies against the antigens which are inherited from the father, okay, and these antibodies then cross over and do the hemolysis and decrease the platelet count, and it occurs in first pregnancy in 50% of cases, okay. So what is happening is the antibodies are being produced by the mother against the antigen which are inherited from father, okay. So in neonatal autoimmune thrombocytopenia, mother has autoimmune disorder or immune thrombocytopenia. So mother already has antibodies against some antigen, okay. So the target platelet antigen are present in the mother and fetus, so they are present in both, and mother is producing the antibodies against their antigen, and therefore mother has thrombocytopenia. So how will you differentiate between this is that you will do the mother's CBC. if the mother has decreased platelet count and the baby has also decreased platelet count, okay, so it means, and mother has some history of autoimmune disorders or immune thrombocytopenia, that means that the infant has neonatal autoimmune thrombocytopenia, okay. But however, in alloimmune, mother CBC will be normal, okay, and baby will be having thrombocytopenia. This is very important. You will be asked again and again. In mother CBC is normal, baby CBC decreased platelet, okay, and here both are decreased. If a child presents with headache, visual disturbance and hormonal imbalance, headache, visual disturbance and hormonal imbalance, look for craniopharyngioma. This is a very commonly tested, very commonly asked question. Look for this one, craniopharyngioma, okay. So that was all for today. Thank you for watching.